chromosome dominant, and they want to know, does their baby have cystic kidney disease? Have they? And that can be challenging early in pregnancy, and I will cover that. And then I'll cover the ciliopathies, which are both adult and infantile polycystic kidney disease. And I will talk about the other ciliopathies. And then I will finish with the very last group, which is the very challenging group of hyperechogenic kidneys, no cause found. And then finish up with some take-home messages and clues to how to go forward in the morning when you go to work. So let's start with the most common situation. And I think many of you in the room will have come across situations where you see multicystic dysplastic kidneys. And the thing about them is that they are not renal in shape. So the normal kidney looks something like this. That's a normal reniform shape. But multicystic dysplastic kidney, you completely lose the renal shape. And it is highly variable as to what the shape of the kidney is. And the sizes of the cysts vary, and the sizes of the kidney vary. But there is a huge variation that you may see in multicystic dysplastic kidneys, and there are some very important clues and some very important take-home messages which I would like to mention. The first point to mention is that when you've got multicystic dysplastic kidney, in 80 to 90% of the cases, only one kidney is involved. And if the other kidney looks normal, the prognosis for the pregnancy is excellent. So if you look at the other kidney, it is important, however, that you monitor the patient during the pregnancy, because about somewhere between 5 to 40% of these will develop problems in the contralateral kidney. And therefore you need to examine that kidney in detail, looking for a duplex system, a pelvic kidney, and so on. Also, you need to consider about genetic testing, because on the published data, somewhere between 7 to 40% of these are associated with a chromosomal or genetic abnormality. And therefore, even if it is isolated single kidney, we do offer amniocentesis. We also recommend close monitoring of these pregnancies, because you can get sudden enlargement of the kidneys later in the pregnancy. And in some of these patients, we recommend a cesarean delivery for gross enlargement of multicystic dysplastic kidneys. So it's important that you monitor these during pregnancy. For most babies, when you make a diagnosis of a unilateral MCDK, you will find that the outcome for these pregnancies is completely uncomplicated. No problems in the third trimester, no rapid increase in size, normal chromosomes. And then the patient says to you, Simon, what's going to happen to my baby after it's born? In the past, we used to recommend nephrectomy because of the risk of renal cell or Wilms tumor, until more recently, data does not support that change. In fact, if you wait, these will regress after birth, that the kidney will shrink and atrophy and disappear. So the management of multicystic dysplastic kidney after birth is conservative management and not surgery, especially from multicystic dysplastic kidneys that are less than 6 centimeters in maximum length. Conservative management is the way forward for these pregnancies. When you scan them in the split image, you can demonstrate on one side you have a normal kidney, and on the other you see multiple cysts. When I scanned the kidney yesterday, I spoke about the technique of scanning. Is to have the spine up at 12 o'clock and rotate on one kidney, confirm that it's normal, and then go back to 12 o'clock, rotate on the other kidney, and demonstrate multicystic dysplastic change. This is a very practical approach to examining the kidneys that I demonstrated yesterday. Important to go ahead and examine the rest of the renal tract, just to make sure that there is no signs of external genitalia abnormality or any other abnormality. I think it's important when you review these patients, same patient back at 28 weeks, you do the exact same thing. You compare the kidneys side by side. And now you see the kidney has increased significantly in size, but you do a split image and compare it to the other side. next thing I do is to move to a higher frequency probe. So in the next image, I then take out the linear 9 probe, looking at the normal kidney, and then moving to 6 to 15 megahertz, demonstrating the kidney on the right-hand side with the multicystic dysplastic change. It's important to consider the differential diagnosis of pylectasis. But each of these individual cysts do not communicate with each other. And they are also highly variable in size. This demonstrates all the different appearances that you can see with multicystic dysplastic kidneys. And you will see for all of these examples, no one case is the same. They are all different, but they all share the same overall features in that you lose the reniform shape, the kidney shape, and you have multiple cysts of differing sizes, and 80 to 90% of them are unilateral. It is very different when you see this picture, where you see both kidneys are involved, and when you've got bilateral multicystic dysplastic kidney disease, and this carries a terrible prognosis. To make sure that it is multicystic dysplastic kidney, and that you're not looking at an adrenal tumor on one side, you then move to the bladder and show the umbilical arteries bifurcating either side. There is no urinary bladder. You will also find at 18 to 20 weeks, there will be no liquor. This is a terrible condition, a terrible diagnosis, but bilateral multicystic dysplastic kidney is only in about 10% of cases. Remember, with any situation where you have bilateral renal disease, also go ahead and look at the heart, because these get renal hypertension, angiotensin-induced hypertension, and they get a secondary cardiomyopathy. So you can see enlargement of the heart and thickening of the ventricular walls with the pericardial effusion. It doesn't matter what the cause is of bilateral renal disease, is that they present with this appearance of renal hypertension. You also see it with the infantile polycystic kidney disease, which I will come to show you. There are variations in multicystic dysplastic kidney disease, and I want to show you these variations. In this lower moiety of the kidney, it's normal, with a normal renal pelvis. In the upper moiety, you've got multicystic dysplastic kidney. So this multicystic dysplastic kidney will have more normal function in the inferior pole. The superior pole is got MCKD because there's obstruction of the second ureter. The understanding is that multicystic dysplastic kidney, most of these are caused by obstruction of the ureter very early in the pregnancy. So remember, when you see MCKD, don't assume it is the whole kidney that is involved. Remember to examine the both upper and lower pole, looking for a duplex system. So this is looking with a high frequency probe. You can see the completely normal renal tissue in the lower moiety and the cystic change in the upper moiety in a duplex system. You may also see multicystic dysplastic kidney on one side in a fetus where you see very little liquor surrounding the fetus. The heart looks enlarged, there's MCDK on one side, but it is not a case of bilateral multicystic dysplastic kidney, but rather there's a case of a unilateral multicystic dysplastic kidney, and the contralateral side, there is renal agenesis. So remember when I said that somewhere between 5 to 40% will have problems on the opposite side. It may be mild vesicular reflux, or it may be, as in this case, renal agenesis. And when you look at the bladder, you will see no fluid. So unilateral MCDK and renal agenesis on the contralateral side. When you look at this case here, you can see that this kidney here has got multicystic dysplastic kidney, and when you look at the contralateral kidney, you can appreciate that there is a duplex system on the contralateral kidney. Anytime that I see there is duplication on the contralateral kidney, the next step is then to go to check for any signs of renal pelvis dilatation. So when I look at the kidney with duplex in it, these are the ones that will obstruct later in the pregnancy. These are the ones which you need to follow very closely. It's important to make make sure when you're faced with this problem that you targeted the other kidney to check that you see that there is a duplex system. So once we get our screen back, I will show you the kidney on the opposite side. I'll draw the image while we're trying to get her back on the screen. And you can now appreciate that you have a renal draining system here and a draining system here. So this is an example of a multicystic dysplastic kidney on one side and the contralateral kidney demonstrating a duplex system. So what I'm doing is going through showing you examples of variations that you may see with multicystic dysplastic kidney disease. Go back. So there on the right hand side, the left hand side shows the multicystic dysplastic kidney and the right hand side shows the duplex system. With regard to the other abnormalities that you may see with regard to multicystic dysplastic kidneys, it is important to check for abnormalities outside the renal system. Important to check the skeletal system, check for cardiac abnormalities, and check for central nervous system abnormalities. So when we go through those, I'll show you examples of when you see unilateral multicystic dysplastic, that you may also identify cardiac abnormalities. The example that I will show you will be a baby with unilateral multicystic dysplastic kidney and also has got pulmonary stenosis. I will show you an example of a unilateral multicystic kidney where the baby also has cerebellar hypoplasia and ventriculomegaly. So, yeah, we're good. It's not turning to the next page, is my only problem. Okay, just let's escape out of the presentation. Discard. Don't touch anything for a second, please. Just wait for a second. Okay, you may lose the screen. Don't worry, don't touch anything. Please don't touch anything. Just wait for a second. We'll come back.
Ngược đầu rồi.
Don't touch anything. Just wait, please. Yeah, it'll come back. It's crossed. No, don't touch it. You may ask the question, had the diagnosis ever been made in the first semester of pregnancy? We reported on the first world case of multicystic dysplastic kidney in the first semester of pregnancy back in 2019, where we could appreciate that the multicystic dysplastic on this side and a normal kidney on this side. But this is extremely rare. And you talk over 30 years of scanning, I've only made 2 cases where I've suspected multicystic dysplastic. So this is a patient at 14, are you kidding me? This is a patient at 14 weeks of gestation here where the kidneys appear slightly abnormal, but the most striking finding was the lipovolume was slightly reduced, and that's what's called the sonographer's eye. Now when you look here at 14 weeks of gestation, you can see how subtle the finding is of multicystic dysplastic disease at the first trimester of pregnancy. Now watch the same patient 2 weeks later, and now you have all the features of multicystic dysplastic change. So you can see how difficult it is in the first trimester of pregnancy to make this diagnosis. And for this patient, a terrible prognosis because it is bilateral renal disease. Then we move on to the next group, which is the autosomal recessive polycystic kidney disease, infantile polycystic kidney disease. This is a condition which about 40% of these will present prenatally, some of them will present postnatally, some of them will present as juvenile polycystic kidney disease. But the ones that we see prenatally, the 40%, these present with gross enlargement of the kidneys. They are an example of the ciliopathies, and I will talk about the ciliopathies, but this is one of the most common ciliopathies. So you have a gene mutation resulting in malformation of fibrocystin, polyductin protein, and the key function of that protein is to drive the operation of the cilia in the collecting ducts. And what happens is you get a gene mutation, malformation of the protein, and cystic dilatation of the collecting ducts in autosomal recessive polycystic kidney disease. And you get this gradual change that occurs over the pregnancy with gross dilatation, where sometimes the kidneys are up to 10 times the normal size that you would expect. The gene mutation that occurs in these is the PKHD1 gene on chromosome number 16. And most of these that you see on the prenatal, you will identify at the mid-trimester scan. Again, not the first trimester scan. They typically are grossly enlarged in the third trimester of pregnancy, and they present with anhydramnios. No fluid is identified within the urinary bladder. So this is a patient at 30 weeks of gestation, where you see gross enlargement of the kidneys. There's a kidney on this side, and with these you will find that you get an enlargement of the abdominal circumference. So if you do a good exercise without changing magnification, is compare the abdominal circumference to the head circumference and do a side-by-side assessment of the two, and you realize how grossly enlarged the abdomen is in this fetus with infantile polycystic kidney disease. And next, I take out a linear 9 probe and I compare that with the linear 6 to 15 probe examining these kidneys. And you can see almost the thickening of the collecting tubules, these tiny hyperechogenic spots that you can identify with the high-frequency linear transducer. Moving on to this patient with the MRI, you can now appreciate the gross enlargement of the kidneys in the fetus with anhydramnios. I don't think there's an indication to do MRI unless you suspect there is some coexistent abnormality, as in this case, with the grounds for which we did the MRI, in that we felt that there was a possibility of a agenesis of the corpus callosum. Again, another part of the ciliopathies that you may get agenesis of the corpus callosum or cerebellar abnormalities. But this was a patient who wanted to continue the pregnancy and consider afterwards renal transplantation. Normally we would not arrange that. Other less striking examples, this is a patient at 25 weeks of gestation. If you go to work tomorrow morning and you see this, it will strike you that the kidneys are bright. It will strike you that the kidneys are reniform in shape, so there's no loss of the kidney shape, but they are bright, and secondly, they are enlarged. And that's what strikes you. And the second thing that strikes you is that when you look at the urinary bladder, there is some fluid in the urinary bladder, but there is no fluid surrounding the baby, or there is moderate to severe oligohydramnios. So that combination presenting early in the pregnancy with enlarged hyperechoic kidneys is typical of infantile polycystic kidney disease. But this case is not as severe as the first one I showed you. Again, you look at the heart, looking for cardiomegaly, cardiomyopathy, and in this case, a cardiothoracic ratio of 58%. 50% is the normal cardiothoracic ratio. So these are the typical appearances of infantile polycystic kidney disease. You can get variations on infantile polycystic kidney disease where you get these hyperechogenic changes in the renal pyramids, and they can look, in a sense, like neonatal hypercalciuria. But you do not get hypercalcemia in a fetus under any circumstances. And while it may mimic a nephrocalcinosis, that diagnosis has never been made in a fetus prenatally. In fact, what this is a case of infantile polycystic kidney disease, a variation of it, which a wide exome sequencing realized that this had been inherited from both the parents with a single gene mutation, again relating to PKHD1 mutation. So the next group I move to is the adult polycystic kidney disease, and this is a challenging group because they present with mild increase in kidney size, but different to the other two cases I've mentioned, the corticomedullary differentiation is normal, or in fact is exaggerated. So the uniformly hyperechoic kidneys or multiple large cysts is not seen. It's a much more subtle finding, where you see that the kidneys look a little bit larger than they should with normal corticomedullary differentiation. You say to me, Simon, so how do we make the diagnosis in these patients? For most of them, we make the diagnosis because the mother comes in telling me that she's got polycystic kidney disease. and it's an autosomal dominant condition, so I'm going directly looking in the baby's kidneys because I know there's a high chance that the baby will have inherited from the mother. So I scan the mother first, and then I go on to scan the baby. That would be 80% of them. The other 20% is the mother has no change in her kidneys and liver. There's no suggestion or history. And I simply find in examining the renal tract that the kidneys are big. And I'm asking the question, are they big normal or are they big abnormal? So let's walk through examples of this. If you look at it, let's say 80 to 90% of these, one of the parents is affected, and these are the gene mutations. And remember that corticomedullary differentiation is preserved in these. So all you see is a slight increase in the renal size. And that's why we have these charts. And this is the chart that I would recommend when you are faced with a situation where a baby presents with enlarged kidneys. This is the chart that I put out because I need to work out over time during the pregnancy, every 2 weeks, do these kidneys increase disproportionately in size? Sometimes I cannot make the diagnosis on a single examination. So you go to work tomorrow morning and you scan this patient at 32 weeks of gestation and you see that the lipo volume is normal, the bladder is normal. But when you look at the kidneys strike you because you can see there's corticomedullary differentiation. But when you measure the length of the kidney is well above the normal range, and now you are suspicious. What would I do next? I would then take out the probe and examine the mother's kidneys and liver, because there's a possibility that the diagnosis of multicystic dysplastic kidney has not been made in the mother yet. It may be the first time you make the diagnosis because you're examining the baby. So remember to examine the mother's kidney and examine its liver. Another example of enlarged kidneys that are slightly hyperechoic, but there is normal corticomedullary differentiation, unlike infantile polycystic kidney disease, unlike multicystic dysplastic kidney disease. In this case, when you look at this, the mother comes in to me, she tells me her liver is okay, but her kidneys are polycystic. She's got adult polycystic kidney disease. And then she asked me to examine the baby at 14, 15 weeks of gestation. You can see how challenging it is to make that diagnosis. Because I know the mother's got adult polycystic kidney disease, I'm highly suspicious that the baby has it as well. But the size of the kidneys were only borderline increased, and if I did not know the mother's history, I would not have made that diagnosis. It's only by following her during the pregnancy that I then realized that the diagnosis is that the baby has inherited the same gene mutation. This mother comes into me with the history. She's got liver change, she's got cystic liver change, and she also has cystic renal change. And when I plot the baby's renal length, I find the baby's renal length is above the 90th centile. So similarly, I am suspicious in this baby that there is also adult polycystic kidney disease presenting in utero. So this is the 40% I'm showing you that present in utero. The other 60% will show no signs. So if the mother has got polycystic kidney change, and she basically wants to know, does my baby have it? You cannot give certainty if the kidneys look normal on antenatal ultrasound. You can, however, offer an amniocentesis and offer wide exome sequencing or targeted single gene sequencing for the gene mutations I've described. They are the three groups I've covered: multicystic dysplastic, infantile polycystic kidney disease, and adult polycystic kidney disease. The last group I'm going to present to you are hyperechogenic kidneys for all the other reasons, of which I will talk about the ciliopathies. I've already talked about the ciliopathies related to adult and infantile, because both of those are part of the ciliopathies. I now want to talk about the other ciliopathies that can cause hyperechogenic kidneys. If you ever look, every single human cell has got on it a cilia. And the cilia, if you look at it, the disorders have been 35 different disorders have been reported with an incidence of about 1 in 2,000 of the ciliopathies. The other renal conditions that may occur and affect the kidneys are Bardet-Biedl, Meckel-Gruber, Joubert, and the other lengthy list of ciliopathies that may cause renal disease. So if you are faced in a baby with hyperechogenic or enlarged kidneys, it's perfectly reasonable for you to consider doing an amnio and exome sequencing if it does not fit into the three categories which I've just described in the previous 20 minutes. These are extremely challenging diagnoses. The cilia are interesting. You ask, what do the cilia do? What's the purpose of a cilia? The purpose of a cilia is to essentially, they're like an antenna on the cell, telling the temperature, telling the light, the osmolality, the chemical composition, and the hormonal environment. And depending what the signal is, it tells the cell to do this or to do that. It's an instructional process of determining an environment and determining chemical change as a result. If the cilia are dysfunctional, it can result in renal abnormalities, skeletal, CNS, eye, and so on. Today we are covering the renal. And if you look at the renal ciliopathies, I've spoken about the autosomal dominant recessive. I will now talk about the Meckel-Gruber, the Bardet-Biedl, and the others. So when you go in to do this scan, and I showed this in my first semester presentation of a baby who has an encephalocele. And remember, we spoke about encephaloceles, that the next step after doing that is then to look for cystic renal change. And then the next step after looking for cystic renal change is then to go ahead and look at the fetal hands or look at the fetal feet and look for evidence of polydactyly of the hand and feet. And then you're looking for the specific gene mutation. This is an example of a ciliopathy giving rise to enlarged cystic kidneys that does not fit with any of the three previous I've described. In this case here of Bardet-Biedl syndrome, again, slightly enlarged kidneys at 16 weeks of gestation, and when you look at the feet, you see polydactyly, post-axial polydactyly. So these babies, the key features you see is post-axial polydactyly, hypogonadism, central obesity, and cystic kidneys. But the two things we pick prenatally are the kidneys and the polydactyly. So if you're ever faced with cystic change in the kidneys that does not fit the classic appearances I've described, you need to go looking at the feet in terms of looking for polydactyly, either as part of Bardet-Biedl or part of Meckel-Gruber syndrome. And then there's Joubert syndrome, which we've described yesterday in the setting of where we see Joubert syndrome. Remember, part of Joubert syndrome, it's a ciliopathy, and therefore you need to go on to evaluate the kidneys, looking for cystic change within the fetal kidneys. And as part of the ciliopathy, not only in the setting of that, you will see ventriculomegaly, and you will see a baby with a dysplastic corpus callosum, that streaky change which I spoke about, with corpus callosum dysplasia. And in the same baby, when you go to examine the kidneys, you will see that there's gross cystic change in the kidneys on the left-hand side and the dysplastic corpus callosum on the right. Again, when you see that combination of CNS midline changes in the corpus callosum and you see the cystic kidney disease, again, you are thinking of the ciliopathies and you need to think of a Joubert syndrome. Leaving the ciliopathies and going on to one other group. Let's say you have the ciliopathies, there's no signs or features of any of the ciliopathies. There is one thing you need to think about, and this is one that can trick you so easily because they can be so subtle and sometimes unilateral, is the HNKB1 mutation, or not mutation, deletion. So this is a micro deletion in chromosome number 17, sometimes referred to as 17q12 deletion syndrome. They have different names in the published literature. Sometimes more recently referred to as the HNF1B disorder. So in this condition, what you are faced with is babies who will have renal tract abnormalities. They also have later in life neonatal delay, developmental delay, behavioral abnormalities, and 40% of these children develop MODY, which is a mature onset diabetes of the young. An important diagnosis to make because there are implications beyond the kidneys when you make these diagnoses. So how are you faced with it? This was a baby who came in at 33 weeks of gestation, and we felt the kidneys were abnormal in appearance, but it was extremely subtle. At first we thought that this was likely to be multicystic dysplastic kidney disease, felt that we could see there was cystic change in the superior pole of the kidney, we wondered whether was this a duplex system with which the lower moiety was normal, there was possible obstruction of the upper moiety. But when we looked at the upper moiety, we could see that there was normal parenchyma in some of the upper moiety, whereas typically with multicystic dysplastic kidney, when the upper moiety is affected, you see cystic change in the upper moiety. It didn't present like that. So when you're faced with this scenario of kidneys that don't quite fit in with multicystic dysplastic, they may be slightly enlarged, they may be hyperechoic, you need to consider 17q12 microdeletion syndrome. And for that, all you need to do is to run a microarray. And lastly, I finish up with the last group. This is a group of mixed, what I call a mixed bag, where you get hyperechogenic kidneys which don't fit into any of the conditions I've described. And when you look at this case, this is the mother who came in, the kidneys were 2 standard deviations above the mean for gestational age. The kidneys look slightly hyperechoic, not dramatic, but the history was she was taking naproxen 2 grams TDS during the pregnancy for severe arthritis. And that was the reason that the kidneys were enlarged. So, including in your differential diagnosis, it's important to take a history where you have slightly enlarged kidneys that are hyperechoic. This is a patient with Beckwith-Wiedemann syndrome, which is another differential diagnosis which you need to consider with enlarged cystic renal change. Bacterial is a rare cause for cystic renal change. So, you know, as part of bacterial, the R represents renal change. So when looking for the renal change, you are looking for a duplex system, you're looking for a multicystic dysplastic kidney change, you're looking for a hyperechoic enlarged renal change. And when you look at the vertebra in the same baby, you can see gross disorganization of the vertebral column in a baby with battery. So that's another one. And then there's hyperechogenic kidneys that don't fit into anything. These are extremely challenging. A patient comes to see you on Monday morning, you see the kidneys are above 2 standard deviations from the mean, there's corticomedullary differentiation, if they're hyperechoic, you do an amniocentesis, and it comes back with a normal result. You extend to doing an exome sequencing, and there's no gene mutation. And the patient says to you, Simon, what's wrong with my baby's kidneys? And for those ones, they're extremely challenging to cancel. But in 50% of these that present that don't fit into a category where no cause is found, the outcome for these is very, very good. The patients need to be counseled favorably. So these are examples of patients who were investigated for all of the conditions above, who present with hyperechogenic kidneys, normal corticomedullary differentiation, increase in renal size, but no cause was found. Lipo volume was normal, bladder volume was normal, and the outcome for these babies was normal. So on that note, I finish up with the very last group very quickly, is cystic renal dysplasia. And this is pretty easy because you identify that there's obstruction relating to most commonly lower urinary tract obstruction related to megacystis. Remember, when you're faced with a baby where there's a dilated urinary bladder, in this baby here there's also urinary ascites, you see there's a 3-vessel umbilical cord, the bladder has ruptured, and then when you go to look at the kidneys, you see the kidneys are hyperechoic. This is a very mild form of cystic renal dysplasia in a baby with posterior urethral valve syndrome. When you take out a high-frequency transducer, you see now that the renal parenchyma is hyperechoic. This is not multicystic dysplastic kidney disease because the renal pelvises are all communicating with each other, and all of them are the same size. You're not looking at cysts of multiple different sizes. This is another case of megacystis, but this cystic change is much more dramatic. Now when you look at the kidneys, they are renal-form in shape, but you can see multiple peripheral microcysts, which is another feature of how cystic renal dysplasia presents. This is earlier in the pregnancy, where you can see that almost like calcific change, punctate calcification around the periphery of the kidney. And in this case here, you can see the kidneys are uniformly hyperechoic. So it's quite variable with cystic renal hyperplasia, from hyperechogenic renal parenchyma, the formation of cortical cysts, but they all are renal-form in shape, and they all show signs of obstruction. and therefore they are fairly straightforward diagnosis. So in summary, multicystic dysplastic kidney disease is by far the most common condition. In the vast majority of the cases it's unilateral, but remember the association with extra renal malformation, cardiac, central nervous system, and remember to examine the contralateral kidney for any evidence of a pelvic kidney duplex system or absence of the contralateral kidney, particularly early in pregnancy. For the autosomal dominant, remember if you're ever faced with a situation with the autosomal dominant, consider to examine the patients. And when you've got bladder obstruction, look closely for evidence of secondary renal dysplasia. For the ciliopathies, the other major group, when you're faced with hyperechogenic kidneys, remember to consider exome sequencing. Thank you very much for your attention.